Okay, morning. We are going to begin. Um, it's a great pleasure for us to welcome in Le Mans for the second GECO Spine meeting. Today we are going to discuss about an uncommon topic for a Spine Congress. Usually it's easier to speak about success rather than failures and complication. But it's very important to know this problem to how to avoid it. And I think we can perform TDR knowing causes of complication. It's also necessary to know the strategy of revision and reoperation. I give the floor to Dr. Berg, my co-president.
Thank you. Good morning, everybody. I'm part of the international side of this. I'm so happy to see that it's not only a lot of French surgeons, but as I heard it, we are representative from 14 different countries here. This is a very good meeting that really focuses on one part of the wide and huge spine area, and I think, as Dr. Rakover told us, we've been talking a lot about the good results. We have to also focus on to avoid complications and how to handle if you ever see them. So I hope this will be a good day for you, everybody. Thank you.
I think you download the application on your smartphone, and you can evaluate each session. Okay.
Good morning, I am Jean-Yves Lazenec, and I am the moderator with Dr. Rischke regarding the first session. As you know, we are here to discuss in a very open way about the complication. All of us, we are friends, and we are here to analyze in a very honest way the problem we are facing. And I think it is very valuable to act like this, and we can obtain a lot of new information. So the first session we shall co-moderate. I shall co-moderate with Dr. Rischke, is about failure and complication of lumbar prosthesis. I am still old-fashioned. I still have the paper, but if you look at the app, you have all of the program.
Then I would like to announce the first speaker. Rakover, please tell us about the perioperative complications of lumbar TDR. Thank you.
I am going to give my own experience of anterior approach. Outcomes of TDR could be affected by failures of the implant, but especially by perioperative complications, intraoperative or early postoperative. Most of these events are linked to anterior approach. The first structure leading to complication during this exposure is the left common iliac vein, but there are many anatomic variations of aortic bifurcation and vena cava confluence. It's always necessary to identify and mobilize the LCEV. It's also necessary to respect two nervous structures, the superior hypogastric plexus and the left sympathetic trunk. I performed 1006 anterior exposure by left side mini open for DDD treatment. You see the casuistic, 6026 TDR, including 102 hybrids, and 378 ELIF. You see operative time, blood loss, and hospitalization duration. The most frequent intraoperative complication is venous injury, 9 on the LCEV, 2 on the iliolumbar vein, and 1 on the vena cava. I required the help of a vascular surgeon 7 times. No arterial injury in this series. No deep thrombosis. Only one arterial thrombosis on the LACA treated by percutaneous angioplasty. And you saw also retrograde ejaculation, 7, vaginal dryness, 3, and the most resolved. Finally, 2 neurologic deficit, and you see the other minor complication. No death, no major sequelae, no deep infection. One early revision at D6 for prosthesis in malpositioning, lateral positioning. 4 early reoperation, 1 hematoma, 1 for angioplasty, and 2 posterior root liberation. There was no significant difference regarding the type of implant, and there was higher vascular complication in L4, L5 involving obesity, and at the beginning of the experience. In this systematic review, you have 14.1 overall complication, 9% intraoperative, and 5% postoperative. The most common complication is always venous injury, around 3%. And you saw also 2.7 retrograde ejaculation. The rate of vascular injury varies from 1.9% to 3.7%, but Cheriano in vascular surgery relate 24% of vascular injury requiring reparation. The most interesting is the study of brow, 1.4 major vein laceration, and 0.45% of left iliac thrombosis. There is more often vascular injuries during instrumentation than during exposure. Among FDA trials, it's only Blumenthal study compare TDR and ALIF. Is similar as the rate is similar for overall complication, retrograde ejaculation, and a little bit increases for venous injury. Finally, for stable risk factor are L4, L5 involving obesity, osteophytes, disc inflammatory, lumbosacral transitional vertebrae, and of course, revision surgery. Mogenam demonstrates that obesity increases vascular injuries and perioperative complication rates, and exposure L4, L5 involving increase only vascular injuries. Avoid complication. Most intraoperative vascular injury occur because vessels are incorrectly identified, dissected, and controlled. A complete liberation of the vessel is always necessary before mobilization and retraction. And the learning curve is important. In L5, S1, exposition is easier. I recommend blunt dissection with a peanut cleaner without diastema to avoid damages on superior hypogastric plexus. Dissection should be started right at the wall of the left iliac artery. Ligation and transection of middle sacral vessel are often necessary. In L4, L5, I prefer identify the LCV and iliolumbar vein. I begin the dissection above L4, L5, and I transect, ligate and transect fourth lumbar vessel. If the mobilization of iliolumbar vein is not sufficient, it's necessary to ligate iliolumbar vein. To debate the first perioperative TDR, it could improve the safety of the approach and reduce the operative time, but literature data were limited and demonstrate mixed benefits. In my practice, it's not routine, but I use only in a case of lumbosacral transitional vertebra. I think the 3D CT angiography is the best solution to define the free vascular window, but can predict the adherence between the vessel and the CVA ligament. Second debate, three articles, three conclusions. Incidence and type of complication were the same for vascular and spine surgeon. Senior spine surgeon was more efficient than a team with access surgeon, but 3% of case required vascular surgeon assistance. In conclusion, rate of TDR major perioperative complication is low. Adverse event could be avoided according to a correct execution of anterior approach and a good selection of the patient. Anterior approach is a safe procedure if it's carried out with a great respect of the vessel and the neurologic structures. Good positioning of the implant, depending a good exposure, is the first condition of long-term successful results. Thank you for your attention.